Hello all, I'm Professor Dragonovich from the School of Public Health and Preventive Medicine. Welcome to this presentation in which we're going to run through the critical appraisal template for answering a question around harm, specifically if you choose a study that is a case control study design. So the template for case control studies and RCT cohort studies relating to harm is fairly similar, with the exception of one question relating to attrition bias. Of course, this is a bit of a redundant question given the fact that case control studies are all retrospective, so you're not going to have any dropouts or attrition bias in case control studies. What I'll do is run through the main sections of the critical appraisal guide. Like I said, very similar to the RCT cohort study appraisal guide for questions around harm. We'll focus on the methodology and then run through the results and the application of the paper to your patient scenario. So the first section relates to the methodology and just trying to tease out its validity. The first question for studies around case control studies is to identify the cases and the controls. So in this case, the first question is for you to identify how the cases were defined and how the controls were chosen. So were they matched? Was it a 2-to-1 ratio? Were controls sourced from the same pool as the cases, or a similar pool I should say? All those features that you need to tease out. Secondly, how was the exposure identified across the two groups? So was it through questionnaire design, interviews, any other data linkage? And was it consistently applied across both groups? So if we're looking at particular exposures, we want to make sure that similar methods were adopted when trying to identify the risk factors across both cases and controls. Now, the major thing with case control study designs is being wary of confounders. So in this case, if there are any differences between the groups in terms of baseline characteristics, we want to identify them, and we also want to identify whether or not any statistical adjustment was taken into account. So if we're looking at a particular study design and we've got more people aged 50 to 60 in one group in the controls as opposed to the to the comparison group, we want to, well, be able to highlight that there isn't any difference between those two groups with respect to that particular factor, and if any adjustment for that differences between the groups was in fact made. And the fourth question we want you to, I guess, focus on is just trying to identify what type of case control study was actually performed, and were there any major limitations associated with this design. So I guess what we're looking for here is seeing whether the data was linked in any way. So if we're looking at people being diagnosed with I don't know, lung cancer, was that diagnosis linked to a state or a national registry that could confirm the diagnosis? So trying to identify as robust a process as possible, or conversely identifying that this may be a limitation with the particular study design. So what are the results? So again, what we're looking at here specifically for the case control studies is an odds ratio. So the majority of the time the results should be reported as an odds ratio. It's not possible to calculate risk because that requires incidence, and case control studies being a retrospective study, it's difficult to calculate the incidence in that respect. If your study, having said that, there is a process from a statistical point of view to convert odds ratios into relative risk. So if your case control study does report a relative risk, do so, report that, but then use the numbers available to calculate your own odds ratio. From that, interpret the association between the exposure and the outcome through your odds ratio. So if you've got an odds ratio of 1.6, this would mean that there's a 60% increase in the risk of in the odds with respect to whatever the particular outcome that you're looking at occurring in the exposed group. The precision, again, we're focusing on the confidence interval, so keep in mind the width of the confidence intervals and how sample size plays a role in the in how narrow or how wide the confidence intervals are, and whether or not your confidence interval includes an odds ratio of 1 and what the significance of that may be. No pun intended. So the third aspect is, again, trying to identify whether or not your study meets the diagnostic test for causation. So there's three questions that we want to ask. So is it clear that the exposure preceded the onset of the outcome? So something like smoking and lung cancer. Is it clear that people first started smoking and then got lung cancer? So that's an example of the exposure preceding the outcome. Is there a dose response gradient? So I've used the example previously of NSAIDs and looking at different dosages and whether or not people still have, let's say, a GI adverse event. So, you know, at lower doses, is that GI side effect as severe as opposed to high doses? So that could be an example of a dose response gradient. Again, a lot of your studies won't have this dose response, I guess, curve, and that's completely fine, just as long as you explain what it is and why it's not possible to determine that in your study. You will receive full marks for that particular section. And then finally, is there any evidence from a de-challenge, re-challenge strategy? So basically it's saying, look, if we have the exposure, does it lead to the particular outcome of interest that we're looking at? So if we remove the exposure, does the outcome also decrease, or is it removed? So again, looking at the example with the NSAIDs, if a patient takes an NSAID, the outcome may be that they have some sort of adverse event. If they stop taking the NSAID, that is, we remove it, does the outcome also either decrease or is it removed? So is the adverse event removed? Again, it may or may not be possible, depending on your question and study, to demonstrate this. Again, if it's not, that's completely fine, as long as you explain what the de-challenge, re-challenge study is and why it's not possible in your particular scenario. Finally, number 4, how can I apply these results to patient care? So again, just comparing the baseline results from your study to your patient. Totally fine if the characteristics don't align, just as long as you highlight that and highlight it as a particular or possible limitation in terms of applying the results from that particular article to your specific patient. What was the magnitude or seriousness of the risk? So here, please refer to your number need to harm and state how many people are adversely affected when exposed to the particular risk factor. And finally, the question, I guess, summing it all up. So, A, is there any benefits in terms of the risk factor exposure that may outweigh the risks? Or if not, should you stop the exposure in the patient in the first instance? So something like that may be smoking. So you may look at, does smoking cause lung cancer? Well, you might get an odds ratio of 15.5 that clearly demonstrates a negative effect. So you'd be hopefully saying, we should remove the exposure, i.e. smoking. Or you may have the other example of NSAIDs and GI side effects, and you may have an odds ratio of 1.1, in which case you could present an argument that the benefits, in terms of the therapeutic benefits, outweigh any potential harms. So So this is your critical appraisal task. Again, much like semester one, follow the same template. So provide a clinical vignette, an information gap, identify the PICO elements, and from those PICO elements, construct your question. Describe what databases you may search, so Cochrane Library, Medline, BMJ best practice, whatever it may be. But for your actual search strategy, only limit it to Medline. Not really phased if you use Ovid Medline or PubMed. You don't need to provide a line-by-line analysis of your search strategy, just a screenshot is more than sufficient, and similarly a screenshot of the potential articles that you've returned from your search. Describe why you've chosen your article, but also spend about a sentence or so on each study explaining why you've chosen to eliminate it. And I'm quite happy if you want to group the studies together. So you may say that studies 1, 2, 3, 4, 5 were not chosen because of reason whatever it may be. In terms of your article, please provide a PDF copy of your article. We won't mark the assignment unless you also attach a PDF copy. In terms of the actual assignment, please combine your first part, that is your clinical vignette, search strategy, all the rest of it, along with your answers to the template in one Word document. Word limit's 2,000 words, due date's 13th of August. However, that may change for those in the rural cohorts because you'll be starting a little bit later. Please submit your assignment to the Year 3B EBCP Moodle site and only an electronic copy. So provide two files, one being your assignment, your PICO, search strategy, etc., along with your template, and the second file being the article itself. You will be able to submit it to Turnitin. You'll be able to do so as many times as you want. The only, I guess, bit of advice is the closer you submit to the date, the longer it may take in order to get a Turnitin score. So sometimes waiting times blow out to 24 hours. The one thing I'll highlight is if you've critically appraised a case control study, please submit your assignment to the drop box that says case control study. If you're using a cohort or RCT, please submit it to the drop box that says RCT/cohort. Apart from that, I think that's it. So again, if you've got any questions, feel free to email me. Otherwise, good luck.